listening to Conferences Online Allergy from Children's Mercy, Kansas City, Missouri. Today is September 8th, 2023. Our topic is diagnostic evaluation for inborn errors of immunity. Our presenter is Dr. Roshini Abraham. She is a professor of clinical pathology at Ohio State University, Wexner College of Medicine, and director of the Diagnostic Immunology Laboratory and Program at Nationwide Children's Hospital in Columbus, Ohio.
So you are listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is Friday, September 8th, 2023. And today we have Dr. Roshini Abraham, who is a professor of clinical pathology at The Ohio State University, Wexner College of Medicine, and director of the Diagnostic Immunology Laboratory and Program at Nationwide Children's Hospital. She is a diplomate of the American Board of Medical Laboratory Immunology and a fellow of the Quad AI and CIS. She is co-chair of the Immunology Clinical Domain Working Group for ClinGen and the Clinical Genomics Resource. And so today she will be talking to us about diagnostic evaluation for inborn errors of immunity. And thank you so much for coming today.
Absolutely, my pleasure. Wonderful to be with a new group of fellows. I've done this, I think this is my fourth year, if I recall correctly, of doing these talks. So wonderful to be with you. As was just mentioned, I'm going to be talking about immunology evaluation for inborn errors of immunity, and the very vastness of the topic, sort of necessitates that in 1 hour we get onto something of the equivalent of a bullet train and just sort of literally speed our way through sort of some key topics. It's really like trying to hold the ocean in a teacup, but I'll try to do my best to give you at least a good sense, overall perspective of how to think about diagnostic evaluation of patients with genetic disorders of the immune system. And hopefully, if you have questions, we can address them at the end of the session. And I'm also available by email, if you have any specific questions at a later time point, and Dr. Miller or Miranda can give you my email if you'd like to get in touch. But just as a refresher for those of you, particularly the first year fellows, is that we have the International Union of Immunological Societies, the IUIS, a subgroup for the inborn errors of immunity or primary immunodeficiencies that every 2 years produces a paper that classifies all the inborn errors of immunity that have been described, as well as any new defects in the last 2 years. So the last classification came out early 2022, so we are slated for another release in early 2024. But at the last classification, I need to go back. At the last classification, we had about 485 genes. And we've actually added several more, so we'll probably cross the 500 threshold in the next iteration. But we have these 10 categories that are really based, when we started maybe 10, 15 years ago, we had 4 categories. Now we've got 10 categories and we've got, close to 500 genes. And so they're divided based on the component of the immune system that's affected, with some overlap. And I've just sort of broadly listed the number of genes. The ones at the bottom in black, the numbers of genes are from the paper, and then the ones I've written in blue on top are some newer defects that were added on. And just as an aside, very quickly, the ClinGen, or the Clinical Genomics Resource, is an NIH-funded global consortium. And through our immunology clinical domain group, we are tackling each of these categories one by one. And we are doing gene-disease validity relationships, and they are published both online and will be available in manuscript form. And we're also doing varied curation. So you can go go to that website. It's if you go to Google and type in ClinGen, it'll take you to the home page, and then you can search. We have completed curation for gene disease validity for antibody or humoral immunodeficiencies. We're in the process of curating these severe combined and combined immunodeficiencies, and we've just started on these diseases of immune dysregulation. So there are many different ways that a patient with an II can come to our attention. Certainly, we used to use the term primary immunodeficiencies as an encompassing term, but mainly intending to mean that there was infection susceptibility. Now we've added PIRD, primary immune regulatory disorders, and the two of them together, go under this group of inborn errors of immunity. That also is a bit of a misnomer because we do have somatic mutations. We do have phenocopies with autoantibodies to key molecules like cytokines. So they're not all inborn, but they are errors of immunity, whether genetic or somatic or phenocopies. But a patient can pop up clinically having one pop up in one of these categories. They could have an infection phenotype, they could have autoimmunity, lymphoproliferation, etc., or there might be a laboratory phenotype of hypogammaglobulinemia or T-cell lymphopenia. Or some patients may have a syndromic phenotype, like, for example, ataxia telangiectasia or Nijmegen-Breakitt syndrome, where they have more than the immunodeficiency, but that is certainly a component. Some patients, of course, come to our attention because of a family history. And then, of course, in this era of next generation genomic sequencing, sometimes they get genomic analysis and then come to the attention of an immunologist. The problem really is that we've just got too many genes identified in a very short span of time. We've got all sorts of permutations and combinations, loss of function, gain of function, varied phenotypes in terms of clinical spectrum that really make it challenging for the average AI physician to, keep track of what's going on and to effectively diagnose and manage these patients. We've got inborn errors of immunity where we have susceptibility to particular pathogens, whether it be mycobacteria, whether it be EBV, whether it be mucocutaneous candidiasis, what have you, or HPV. We've got gene defects that predispose to these certain categories of pathogens. We've got autoimmunity or lymphoproliferation as a key phenotype. And besides having somatic variants, we can have somatic mosaicism within the context of germline mutations. Like, for example, in Wiskott-Aldrich syndrome, you can see different phenotypes from revertant to mutations. So mosaicism is an issue. We can have individuals, chugging along with a germline defect, and then all of a sudden the sky falls down. For example, in X-linked lymphoproliferative disease type 1, due to Sept mutations, SLAM-associated protein mutations, SH2D1A is the gene. Those patients stay asymptomatic till they get an EBV infection, and then all of a sudden you see this fulminant lymphoproliferation and manifestation of the phenotype. And the 10th category in the IUIS classification that you just saw is the phenocopies that we mentioned, which includes, somatic mutations like TLR8 or VEXAS syndrome that's been fairly recently described with adult onset manifestations, or you've got autoantibodies to interferon gamma, to GM-CSF, etc., where you then get a clinical disease that is indistinguishable from the germline genetic defect. I think over the years, our conceptual understanding of these primary immunodeficiency disorders or inborn errors of immunity has evolved. We had a very one-dimensional thought process early on. We thought that you've got a particular genetic defect, you've got a very specific clinical phenotype and immunological defect. But our current understanding is more like this Jackson Pollock painting, a real mishmash of a whole host of things. So it makes it far more challenging to diagnose these patients because you've got a multitude of clinical phenotypes. You've got great variability in genotype, in penetrance, in variable expressivity. So our life is unfortunately going in the direction of the right, the Jackson Pollock, and not in the direction of the left, which is this sort of linear thinking. But for most patients, particularly in our discipline, but certainly in any discipline where these patients are seen, I don't think there'd be a lot of debate on the fact that you need to make a diagnosis early, because if you have a conclusive diagnosis, you know how to manage those patients, you know how to screen family members, you know how to advise for risk. If it's related to newborn screening, you know the success of the newborn screening program and early intervention leading to better outcomes, to making appropriate genotype, phenotype correlations, etc. So there are many reasons why we want to make an early diagnosis. But to make an early diagnosis, we have to know what tools are available at our disposal, how to correlate certain phenotypes, and to come up with a short list of genetic defects, to have a differential diagnosis, and not let your genetic testing tell you which way to go, but rather using the clinical phenotype, the immunological data, and then when you get the genetic data, to putting those three pieces or three large pieces of the puzzle together. But you should have a differential at least to start with, so that you're ordering the appropriate tests. So we have a variety of tools in our tool belt. Certainly flow cytometry is a mainstay because we can do a lot of cellular analysis, both phenotypic and functional. We do use a number of immunoassays, ELISA or otherwise based assays, to look at soluble biomarkers like cytokines and chemokines. We do cellular studies where we interrogate particular pathways of signaling of function. We may do molecular non-genetic studies where they'd be, for example, say looking at TREC in whole blood, not from newborn screening, but doing TREC as a biomarker, or looking at T-cell receptor V-beta diversity by spectrotyping. So those are all molecular analysis that are not really looking for germline defects. And then, of course, you've got your genetic analysis, you've got your SNP arrays, karyotypes, and then not everything is available for the evaluation of these rare disorders in the clinical domain. Labs such as mine, which are clinical labs, we're trying to expand our portfolio of esoteric testing to sort of diagnose, the uncommon patients or the complex patients. But the average clinical laboratory, can give you like TB and K, basic lymphocyte subset, immunoglobulins, vaccine antibodies, but really don't do a lot of the esoteric testing. And so things that are in the pipeline, research pipeline, that may be making its way to the clinical but not yet available, are done in that research setting. So I'm going to start out with newborn screening for SCID. We're now in our 13th year. 13 and a half years since newborn screening for SCID was approved by the federal government and the HHS, and it took about 8 years, well actually 9 years. By the end of 2018, all 50 states in the US were screening for doing newborn screening for SCID using CHEC. There's no state in the US that is doing CREC officially. There are many countries around the globe, including our neighbours to the north in Canada, to the south in Mexico, and certainly Europe, Asia, and out in the far Pacific, Australia, New Zealand, several countries doing it either nationally or as a pilot study. So basically, all of you know that we are looking at TREC, which is an extra chromosomal piece of DNA that is created as a byproduct of VDJ recombination during T-cell receptor rearrangement. That little piece of DNA, because it's extra chromosomal, gets diluted out by cell division. We look at a TREC. There are many different TRECs that are generated in the thymus, but we're looking at a TREC that is generated just prior to the T cells coming out of the thymus into peripheral circulation. It's called the delta deletion TREC, which comes as a part of T cell receptor alpha chain rearrangement. And so we use the TREC as a surrogate marker for thymic function. Is the factory robust, churning out lots of new T cells because they've not had a chance to undergo much cell division in the thymus? They should be enriched in containing these TRECs, and we measure that. If it's normal, we don't do anything. If it's abnormal, then of course we send for confirmatory testing. And then there are tiers of confirmatory testing that I'm going to be talking about. So we have a few different things that we are working on with regard to newborn screening. So, okay, everybody in this country at least is doing newborn screening for SCID. But what is the challenge here is that we're not all on the same page in terms of how we report out TREC results, how immunologists are perceiving and understanding these labels that are provided by the state lab. So we are currently CIS, the Clinical Laboratory Standards Institute, CLSI, and the Association of Public Health Laboratories, APHL. We're working on some harmonization efforts on harmonizing reporting of TREC results, as well as what should be the follow-up testing for TREC. So that's work underway. The CLSI, I'm leading a revision of a document related to TREC screening and harmonization and uniformity in what is done for confirmatory testing, etc. And that document will be published in 2024. But basically, when we get an abnormal result, we sort of first deal with term infants. You know, do they have low TREC or undetectable TREC? Because we want to have a sort of panic button with this term. It's like a fire alarm going off. You got undetectable TREC, whip things into place to do your confirmatory testing. If you've got low TREC and it's a Friday evening at 5 o'clock, you know, you might wonder, you could wait till Monday morning to have the lab do your confirmatory testing. But if it is this panic button, urgent TREC, undetectable, zero TREC, then you want to rouse the lab, and they need to be doing that for you so that you can implement appropriate strategies for management of that patient. And then, of course, you triage based on what you get, because there can be false positives for a variety of reasons. So you do your flow testing to look at naive T cells. You look at recent thymic emigrants, etc., to look at your total T cell, B cell, NK cell counts through TB/NK lymphophenotyping. And if it's abnormal, then you go your way doing genetic testing, other things. If not, you don't take any further action. Now, if you're on the spectrum of being preterm or low birth weight, then again, you realize that you could have a low TREC as a result of prematurity or low birth weight, and you follow a certain pathway. On the other hand, if you have an infant in the NICU who's term but low birth weight, then we treat in this manner, just like we would treat the panic button zero TREC. So we're trying to put this out through this document so that clinicians, you know, it's very hard to dictate to state labs what to do, but at least at this level, you know, of confirmatory testing, when the ball comes into the clinical immunologist court, that we have some uniformity in how we're assessing what is our first tier of confirmatory testing. And then, of course, we're also trying to work with the public health laboratories to harmonize and to make sure that, you know, there is a distinction between low TREC and undetectable TREC, between no panic button versus a panic button, discriminating between term, low birth weight, and preterm versus low birth weight. So the first thing that we do, of course, is to look at lymphocyte subsets, TB/NK. If I'm not sure how many of you have seen flow data before, but typically what we do is we first identify our lymphocytes. They express CD45. They are very low in terms of complexity or granularity, so they sort of sit here down at the bottom compared to your neutrophils, which are high in granularity and bigger in size. They sit up here and they have less CD45 expression, so they're a little to the back of the lymphocytes, and your monocytes are somewhere in between. Now, not many labs use CD14 versus lymphocytes, 4 to 5, to discriminate, but this is really what we call a purity gate. We sometimes get mucky situations here where we can't identify lymphocyte populations properly. So we include this because what would happen if you incorporated monocytes? They're going to show up most of the time as NK cells. Sometimes they can express CD4 and can show up in this gate. So to make sure that you're really looking at lymphocytes, we include this 14, which identifies monocytes. You can see, look at this, how many monocytes? There are a fair number of monocyte contamination. So by having this, we now have a clean population of lymphocytes. Then we look at CD3 positive, CD3 negative, and then we take the CD3 positives and look at 4 versus 8, and we take the CD3 negative and look at B versus NK cells. The other thing that we want to do in our tier 1, beyond looking at TBNK, is to look at naive T cells and recent thymic emigrants. So we look at CD45 RA and RO. RA is traditionally considered to be a mark of T cell naiveness, and RO a mark of T cell memory, and you always have some cells that are in this transition phase that can express both markers. But labs like mine and a few others do not recommend just using RA, RO if possible, because you can have what we call TEMRAs, T effector memory cells re-expressing RA. So TEMRAs are a unique population of T cells. They're quite heterogeneous. They have mainly senescent or terminally differentiated cells. These are memory cells. They're antigen specific. But now, all of a sudden, they've re-expressed RA. So they're no longer traditionally expressing what we think of as the memory marker, RO. So they're going to show up here. And they're not naive T cells, but you're going to think they are naive because they're expressing RA. Whereas if you have other markers like CD62L or CCR7, you can then, make sure that those are not TEMRAs because TEMRAs won't express those homing markers. Or another way is to look for recent thymic emigrants, to take these RA positive cells and say how many of them are expressing 31. Now, 31 positive RA positive cells are considered what we call true naive. These are T cells fresh out of the thymus. They've not undergone any cell division, so they're expressing 31. You can have naive T cells that have undergone homeostatic cell division, not in trigger to an antigen specific response, and they will lose their 31. So here you can see we're taking these blue RA positive so-called naive T cells, but you can see that there's a subset of them that are 31 negative. These are naive T cells that have undergone cell division, whereas these are your true recent thymic emigrants that express 31. These are your TREC positive T cells, that would have the undiluted TREC, whereas here, because they've undergone cell division, they'll have diluted some of their TREC. So here's an example of a baby with a T minus B plus NK plus KIT due to a mutation in the IL-7 receptor alpha chain. You already visually can see this child is very lymphopenic, very few lymphocytes. Again, we have our purity gate, so we are only looking at our lymphocytes, and look at the rather pathetic number of T cells. Whereas you've got a nice number of B and NK cells because IL-7 RA is a T minus B plus NK plus. But this child had a slightly hypermorphic variant, so he has some CD4 T cells, but no CD8 T cells. And if we look at these markers of naive and recent thymic emigrant, we get a big goose egg. We have a few of these transitional cells expressing a bit of RA and RO, but we don't have any true pure RA or RO positive, and certainly no recent thymic emigrants. So this screams SCID, or if you see this and you don't know the genetic defect, you'll think of a thymic disorder like PAX1, FOXN1, complete DeGeorge, etc. Okay, so that is very basic phenotyping and what we would call our tier 1 testing to follow up an abnormal newborn screen for SCID. Now, traditionally, many of people who've been taught for a long time have been taught that, okay, if you're suspecting SCID, you've done your TBNK, naive RARO and all that stuff, you should do proliferation to PHA. And I'm here to give you a different side of that story. So first of all, when we think about PHA proliferation, what are we trying to measure? We're trying to use it as a surrogate for T cell function. We're stimulating with a non-T cell receptor specific stimulant that we call a mitogen, and PHA phytohemagglutinin derived from the red bean is a non-TCR specific stimulant. It causes T cells to proliferate. But what sort of method are we using to measure that T cell proliferation? Historically, labs have used a radioactive label, tritiated thymidine. That thymidine will incorporate into proliferating DNA. So you measure the amount of radioactivity as a surrogate for proliferation. Okay, but several years ago in 2011, when I was at the Mayo Clinic, I developed a flow-based assay for T cell proliferation because I found that I was operating blind with this thymidine assay. I couldn't visualize the proliferating T cells. So if I had a patient with lymphopenia, I really couldn't, narrow down. I couldn't go from a binoculars to a telescope stage, whereas I could with flow. So I switched to this flow method. EDU is a thymidine analog. It also incorporates into DNA. And you can see that when you've got proliferating lymphocytes, you see them all sitting up here like a banana almost. And this is blasts. These are cells actively proliferating, because normally your lymphocytes are like a button down here at the bottom, as you saw on the slide before. But now you've got this whole banana shaped structure because you've got a lot of proliferation, and you can then focus on total lymphocytes, CD45 total lymphocytes, or you can zoom in on the T cell compartment using a marker for T cells like CD3 and identify T cells that are proliferating. What is the advantage of this? Well, I'll come to this in a second. I'm just going to fast forward for a moment. So using the PIDTC, the Primary Immunodeficiency Treatment Consortium data from SCID patients, we tried to compare the data on PHA proliferation in SCID patients using the radioactive versus flow method. And we correlated it with the T cell count. And what we found is that the flow method has greater analytical resolution than the radioactive method in patients with lymphopenia. You can see that you have patients with lymphopenia. These are all patients who are meeting SCID criteria, who have a much higher proliferative response just based on the method that you're using to assess proliferation. And that becomes less obvious when your T cell counts become higher and more comparable. So if you look at these blue dots, they're the flow, and the black dots are the radioactive, and you look at these patients with low T cell counts, less than 200, you see many more of these blue dots up here with higher proliferation than you do with the radioactive method. So what many clinicians don't often recognize is that the method you use can really affect your interpretation of the results. And you might consider somebody with low T cell proliferation, but in the context of T cell lymphopenia. But if you used a different method, they might actually have normal proliferation. So your interpretation is completely, can go haywire based on the sensitivity or the resolution of the method. The second is understanding, what are you trying to assess? You're trying to look at T cell function. Most of the T cell defects associated with SCID really affect T cell development in the thymus. Also, using something like PHA is a non-specific stimulant. If you think of how T cells get activated in our body, it's through this cognate signal, T cell receptor versus peptide in the context of MHC. And then you've got co-stimulatory molecules serving as your signal 2. Then you've got cytokines acting like IL-2 in an autocrine loop, driving T cell proliferation. On the other hand, what does PHA do? It doesn't need this cognate signal. It binds to the T cell receptor directly through glycoprotein residues and triggers T cell activation directly. So it is not a physiological stimulant of T cell activation. It doesn't represent how T cells are being activated. Also, proliferation is just one facet of T cell function. Cytokine production, cell signaling, there's so many facets of T cell function. So we can't put all our eggs in the proliferation basket when we're trying to assess T cell function. We need to know the methodology. So now in the 2022 PIDTC SCID diagnostic criteria published earlier this year in JACI, you can see that for typical SCID, we not only changed the threshold for the CD3 count, we went from CD 300 to 50 cells per microliter, but we took away the need for proliferation, the need for PHA proliferation to make the diagnosis of typical SCID. And we use it only for leaky or atypical SCID, but in conjunction. So it's 1, 2, and 4, or 1, 3, and 4. And we've taken it out for Omen syndrome as well. So this is something to keep in mind, because most of your attendings and people, senior people, they've been used to ordering PHA proliferation to assess T cell function. It's almost a knee-jerk reaction. But what I want you to do is stop for a minute and understand, what are we trying to measure with the PHA? Is it physiological or not? When can it be used? When should it be used? Does it indicate all aspects of T cell function? And understanding the methodology by which the testing is done can make a big difference in your interpretation of the results, particularly in patients with T cell lymphopenia. Okay, now I want to transition from looking at SCID and newborn screening and all of that to talk a little bit about PERDs. PERDs are a growing segment of our inborn errors of immunity. Previously, if we took all our, say, 500 genetic defects of IEIs and we sliced them, 2/3 of the pie were considered to be immunodeficiency predominant phenotype, and 1/3 was considered to be PERDs with autoimmunity lymphoproliferation. But that line is now expanding, where we're getting more and more PERDs, and I think pretty soon the shoe may be on the other foot, where we have 2/3 PERDs and 1/3 with a predominant infection susceptibility. And here I'm just sort of showing you the spectrum of what we would consider immune dysregulation, autoimmunity, lymphoproliferation, hemophagocytosis, hyperinflammation, all those sort of things. And we have a number of genetic defects associated with those. So when we think about immune dysregulation, we think of all these different clinical, i.e., clinical/laboratory features, things like cytokines, lymphopenia, cytopenias are laboratory features, autoimmunity, lymphoproliferation, neoplasia, atopy on the clinical features. So we have many different specialties. They're not all going to show up in AI. They could show up in any one of these. And so there has to be crosstalk. There has to be multidisciplinary studies and interactions to really evaluate these patients effectively. I just want to talk about cytokine storm sort of as an exemplar of immune dysregulation. At one end of the spectrum, you've got your familial hemophagocytic lymphohistiocytosis disorders, your Perforin and your Griscellis and Shedya-Higashis and all those sort of things. On the other end of the spectrum, you've got sepsis, which has nothing to do with inborn errors of immunity. And then you've got a spectrum here, your macrophage activation syndrome, EBV-driven HLH, your other PIDs. And if you look at this side of the equation, you've got host factors. So if you've got monogenic defects, whereas in sepsis, there could be various things, environmental factors that regulate that. But then you've got an intersection of these two where you get this cytokine storm. And on this end of the spectrum, you might have to treat with hematopoietic cell transplantation. On this end of the spectrum, you might have to treat with antimicrobials and several things in between to manage that cytokine storm. So you can see that we've added several layers of complexity when we think about immune dysregulation. I just briefly wanted to show you some new assays. This is a clinical assay that will be available in my lab by the end of October this year. And this is to really assess type 1 and type 2 interferon signatures. For those of you who have spent any amount of time in the inborn errors of immunity, doing immunology or reading about it or listening to lectures, you would have realized that we've got what we call the type 1 interferonopathies, monogenic or polygenic diseases that result in activation of type 1 interferons like interferon alpha, interferon beta. So lupus, for example, could be considered as a prototypic type 1 interferonopathy, but we also have monogenic type 1 interferonopathies, Aicardi-Goutieres syndrome, and several others, several autoinflammatory conditions we see type 1 interferonopathy. Traditionally, people would look at certain gene transcripts associated with type 1 interferon, but here what we're doing is we're taking one of those representative proteins, Siglec-1, CD169, that is induced by type 1 interferon, and we're saying, is it expressed or upregulated on monocytes? In healthy individuals, we don't see very much type 1 interferon unless we have COVID or some acute viral infection, where we, of course, as part of our normal immune response, will transiently upregulate, but then we come back to this baseline status. Whereas in lupus patients who are untreated or in any of these autoinflammatory or type 1 interferonopathies, you can see this beautiful type 1 interferon signature. Now, we also do the same for type 2 interferon, interferon gamma being a classic representative of type 2. We look at upregulation of CD274 or PDL1, the ligand of PD1, and you see in patients with porphyrin deficiency, HLH, this beautiful type 2 interferon signature. So this is a very fast, rapid cellular immunophenotype / functional study, whereby before we even get genetic testing, we are pretty certain that this patient has an FHL or a type 2. It could be a secondary HLH as well, but the bottom line is we've got a very strong type 2 interferon signature. And if we treat these patients with either JAK inhibitor or anti-interferon gamma antibodies like emapalumab, and you get a nice response to therapy, you can use the same assay to monitor response to therapy. More recently, there have been some papers that have come out in Blood as well as in JACI recently, looking at activated T cells and using that to discriminate in patients who've got hyperinflammation related to HLH versus, for example, sepsis. So basically what that does is we're looking for activated CD4 and CD8 T cells. Here I'm showing you just CD8. Human activated CD8 T cells express MHC class 2, HLA-DR. So you can see there's a big population here. We also look at CD38, which can be a constitutive marker in very young children that is expressed on T cells, but in older individuals, it serves as a marker of activation. But if you want to look at it in young patients, we look at this joint expression, the upper right-hand quadrant. So you can see that about 34%, a third of the CD8 T cells in this patient express 38 and HLA-DR, showing that there is activation of the T cell compartment. So whereas you won't see this in sepsis. So you won't be giving cytotoxic treatment to patients just because they've got a cytokine storm. You would do the cellular analysis and identify those patients who've got a true T cell activation who need cytotoxic therapy. And let me just get this here. And people have shown that if you use emapalumab, you can definitely get a response in HLH, but in some patients, you may need to use emapalumab plus JAK1 inhibition using ruxolitinib, because both of them block interferon gamma signaling, and you can see a stronger clinical or more robust clinical response in those patients with HLH-associated hyperinflammation or macrophage activating syndrome. So now veering away from T cells and going to the other part of the adaptive immune system, which is B cells. We don't have time to go a whole lot into detail, but I just want to very briefly talk about antibody responses and what we measure for B cell function. So typically we divide B cell antibody responses into two categories broadly, T dependent or T independent, where they require T cell produced cytokines for isotype class switching, or they don't require that T cell help for mounting an antibody response. But the T independent we divide further into T1, T2 and T3. Now, T3 is very new, but T1 and T2 have been around historically. So T1 would be something like LPS, that has the sort of repetitive polysaccharide subunits, and you can get an IgM antibody response through TLR signaling on B cells. Type 1 independent type 2 responses are the pneumococcal and meningococcal polysaccharide antibody responses. And here we know now that we can get IgG and IgA antibodies as well to pneumococcal polysaccharides, not just IgM. And for a long time, we didn't understand how that isotype class switching was taking place. How were we getting IgG and IgA? And then about 10, 11 years ago, it was shown that there are neutrophils called B helper neutrophils in the marginal zone of the lymphoid follicles, and they produce cytokines that allow these marginal zone B cells to undergo isotype class switching in response to encapsulated pathogens or polysaccharide antigens. So it is not a T-dependent isotype class switching, but rather it's a neutrophil helping B cells isotype class switch to have a T-independent IgG, IgA antibody response to polysaccharide antigens. I'll stop there for B cells with that. Very briefly about NK cells. So we often don't think about NK cells, but we do have several inborn errors of immunity that affect either solely the NK cell compartment or more often than not in a combined immunodeficiency affect NK cells along with T and B cells as well as other compartments of the immune system. And of course, if you've got an NK cell functional or numerical deficiency, you're at higher risk for malignancy, development of malignancies, as well as certain kinds of viral infection, for example, HSV, etc. and HPV. So in blood, we've got two flavors of NK cells floating around. We have our cytotoxic NK cells that are 16 bright, 56 dim. They contain a lot of these cytotoxic granules and are efficient killers. And then we've got our cytokine producing NK cells that are 16 dim, 56 bright, and they produce a lot of cytokines, including interferon gamma. And so 90% of our blood NK cells are cytotoxic, 10% are cytokine producing. And sometimes we look at the proportions of these NK cells in the diagnosis of certain disorders. For example, in GATA2 haploinsufficiency, you see a real diminution of these cytokine producing NK cells, which in conjunction with other cellular biomarkers and clinical features, and of course genetic testing can help you make the diagnosis of GATA2 haploinsufficiency. Now, for HLH and many of these disorders like Shediac, Higashi, Griscelli, etc., where we expect cytotoxic lymphocytes, which are both CD8 and NK cells. We also have some CD4 cytotoxic lymphocytes, but NK cells deal with killing in a totally different way from T cells. NK cells, through spontaneous NK cell killing, really are based on recognition of MHC class 1 on the target cell. So NK cells are activating and inhibitory receptors, and if an inhibitory receptor recognizes class 1 on that cell, it'll say, okay, no, this is a friendly, don't kill it. Whereas if there is no MHC class 1, then it'll say, okay, this cell is ripe for killing. So viral infection or tumor presence can downregulate MHC class 1 and make them susceptible to NK cell killing. From a diagnostic standpoint, measuring NK cell spontaneous cytotoxicity in the lab is not very useful because it is very finicky, very variable, very labile. So we have now really abandoned recommending. If you look at the HLH 2004 diagnostic criteria, you'll say NK cytotoxicity abnormal. But really, in practicality, we don't use that anymore. What do we use instead? What we use instead is this process called degranulation, and we measure CD107 as a marker of that. So here's the cytotoxic granule present in NK and CD8 and cytotoxic CD4. And inside you've got all these bullets, you know, perforin, granzymes, etc. And these bullets are cased in this membrane, in this molecule or cytotoxic granule, and the membrane of which has these other proteins called CD107 or lysosomal activated membrane protein LAMP1, LAMP2, etc. So when a cytotoxic lymphocyte gets activated, this granule that's inside the cell has to move to the surface of the cell. So this CD107, which was previously intracellular and could not be visualized on the surface of the cell, now can be visualized on the surface of the cell because this cytotoxic granule has moved and merged with the cell membrane in a process of activation, you know, just before the bullets like perforin, etc., are released and will kill the target cell. So we use this degranulation of CD107 as a marker for cytotoxic function impairment, whether it's in HLH or other conditions where we suspect a defect in cytotoxic function. Any questions here before I move from the adaptive to the innate immune system? I have a lot of ground still to cover. I hope to make it on time. So just going into the innate immune system, I'll start with neutrophils that we consider to be the first responders of the immune system. So if the T cells and B cells are, you know, the doctors and nurses and staff in the ER, then, you know, your monocytes, your neutrophils, etc., are your paramedics, you know, who are in the ambulance, in the field, dealing with things at sort of the site of the event. And so neutrophils also are killers, not just cytotoxic lymphocytes, but they kill using some different mechanisms. They mobilize superoxide radicals or reactive oxygen species, which through the NADPH enzyme pathway. They also have their own set of bullets or proteases, not perforins and granzymes, but elastase and a variety of other proteases. And then they can extrude what they call traps, neutrophil extracellular traps or nets, whereby they can grab things and bring them into the cell for subsequent killing. So this is an electron micrograph of these neutrophil extracellular traps and nets. You know, are these kind of fibrils that extend outside the cell, and then they can capture antigens, pathogens, and even sometimes nuclear material and bring that back into the cell. So the granules, they have different types of granules, azurophilic, specific, and tertiary granules. Each of these granules contain different types of bullets. And then, of course, we've got the NADPH enzyme oxidase pathway, where basically we're producing a lot of bleach, hydrogen peroxide and bleach, to really kill bacteria. So when we think about the NADPH oxidase pathway, we've got 5 different components in the NADPH oxidase pathway. In the membrane of the endocytic vacuole, we've got GP91 or glycosylated P91 FOX, standing for phagocyte oxidative burst. We've got the P22 FOX. These two are sort of married to each other on the membrane. And then we've got 3 cytosolic components, P47, P67, and P40 FOX. Now there's a new player, a 6th player, called EROS as well, that interacts with the GP91 FOX and is also important for NADPH oxidase function. And so if you've got mutations in any of these genes, you'll get chronic granulomatous disease or CGD. And the sixth player, EROS, is also a new autosomal recessive defect associated with CGD. Now here we've got a very nice quick assay in the clinical lab to assess NADPH oxidase activity and diagnose patients with CGD. But what is important is the pattern of this NADPH oxidase activity that tells us something about the genetics of the disease, but also we can use it to monitor patients, for example, post-gene therapy or post-transplant for CGD. So basically what we're doing is we're taking neutrophils, we're labeling it with a dye, dihydrorhodamine 1,2,3, which is a non-fluorescent molecule. And then we're activating those neutrophils with a non-specific stimulant. And when you activate it, that dihydrorhodamine is oxidized to form a fluorescent compound called rhodamine 1,2,3. And we're measuring the fluorescence of that rhodamine. So here's your unstimulated neutrophil, here's your PMA or non-specific stimulus used to activate your NADPH oxidase, and you see this beautiful oxidative burst with the fluorescence of that oxidized dihydrorhodamine 1,2,3. Here's a patient with classic X-linked CGD. There's absolutely no oxidative burst. The unstimulated and stimulated are overlapping. But what about these, the remaining of these plots? So here you're seeing a partial activation and very limited at that. You know, it's not only just a subset of neutrophils, but it's also significantly reduced in the amount of NADPH oxidase activity. These are the patterns you see with most autosomal recessive CGDs. So your P22 FOX, your P47, your P67. So for example, this is a P47 patient, there's a P67, both are autosomal recessive. So from the pattern, we can straight away say, this is not X-linked CGD, this is autosomal recessive CGD. Now, here's another situation where a patient came who had this pattern, and some people incorrectly interpret this as normal because they think, oh, well, all the neutrophils are positive, etc. But they fail to take into account that normally you would get very high fluorescence if you've got robust NADPH oxidase activity. So yes, all the neutrophils are exhibiting some amount of NADPH oxidase, but it's not very robust. So you have to be very careful in interpretation. You see this pattern with complete myeloperoxidase deficiency as well as with P40 FOX deficiency. P40 FOX does cause a type of chronic granulomatous disease, but you rarely see a lot of infections in those patients. What you see is inflammatory bowel disease and inflammatory manifestations. So the person in the lab interpreting this data has to know what they're doing, otherwise they can give you an incorrect result. This is a patient with hypomorphic X-linked CGD. So this is classic or typical null X-linked CGD. This is a partial loss of function X-linked CGD, looks a bit like these autosomal recessive, and it was genetic testing that identified that this was an X-linked CGD, but he had partial function, so he only had one Burkholderia pneumonia in his life. This is a female carrier, 65-year-old carrier, who's showing 100% skewed lionization at the age of 65. She has a symptomatic son. Her sister is a carrier, but she wound up getting Burkholderia pneumonia because now you can see that all her neutrophils are expressing the mutant and not showing the 50-50 distribution as you would see with random X chromosome or random lionization. So that's something to keep in mind. If you see this pattern in a female, or you see this pattern in a female with either a family history or thing, then you have to think that it could potentially be a female carrier of X-linked CGD with partial or complete lionization. The other thing to keep in mind is the quality of the sample affects the quality of data. If you've got a good sample, neutrophils are very labile, they're prone to death just by sitting around. If you've got a good sample, you get a good result. You've got a crummy sample because it was sitting around for too long or it took too long to transport, you've got a lot of dead neutrophils, you're going to see something mucky like this. And if you're not sure how to interpret, many people will misinterpret this, call it carrier, call it this, call it that, and totally confuse a clinician. So you should always ask for the flow data and make sure that the person in the lab knows what they're doing and how they are interpreting correctly. And if you see this pattern in the side scatter versus forward scatter, you should know. Don't waste your time trying to interpret this. Say that you need a clean sample because you've got a lot of dead neutrophils that is contributing to this background as well as to this reduced population of neutrophils with reduced NADPH oxidase activity. And then this is the first paper published on P40 FOX deficiency back in 2009. You can see how it looks like that pattern. So this is normal, this is X-linked CGD typical, and then this is P40 FOX looking like this over here. Now, in addition, in my lab, we offer specific flow cytometry-based assays to look at individual subunits of the NADPH oxidase proteins. This is easy because we can do a quick assessment and tell you what this specific type of CGD or where the genetic defect is, even before you get the genetic testing results back. So this, of course, healthy control, showing you that we can assess both the neutrophils and monocytes for each of these proteins, GP91, P22, P47, and I didn't show it here, but we can do that for P67, and we're working on this for EROS and P40. But EROS, as I mentioned, due to mutations in the CYBC1 gene, is a new genetic defect for CGD. And it affects NADPH oxidase activity. So you also would have a partial loss of function and impaired DHR result in those patients. The other thing to keep in mind is not just CGD patients can have abnormal DHR results. Complete myeloperoxidase deficiency can give you a false positive. This is not CGD, but they can have abnormal DHR. Patients with glucose 6-phosphate deficiency can have abnormal DHR. Patients with G6PC3 deficiency will have neutropenia and can also have abnormal DHR. So don't think that a DHR test is only specific for CGD. So this pattern, as I showed you in the previous slide, can be seen in P40 FOX deficiency, can be seen in hypomorphic X-linked CGD, but also in complete myeloperoxidase deficiency. And again, if you have somebody in the lab who doesn't know what they're doing, they can misinterpret this and call it normal, but it's not normal. And so you can confirm that by having a hematology lab stain neutrophils on a peripheral smear for myeloperoxidase. Healthy individuals have nice brown staining for myeloperoxidase. Complete myeloperoxidase deficiency, you can see much less myeloperoxidase. These patients often have candida infections, often have pre-diabetes or diabetes. Partial myeloperoxidase deficiency is asymptomatic, so you won't pick them up most of the time clinically. Okay, I'm really at the top of the hour, but I have a few more slides, so if you would bear with me. Just to very quickly go over the concept of integrins and their role in the immune system and, of course, inborn errors of immunity. So we use a variety of integrins to get our leukocytes to go from one place to another. If our neutrophils have to come to the site of a cut, or, if there's a local inflammation, like, we have a pimple or an acne or whatever, and you see pus over there, you know that neutrophils are there at that sebaceous gland blockage site. How do they get there? It's like, how does a letter get to you without an address, right? So these integrins are sort of like the address. They tell leukocytes and neutrophils, monocytes, macrophages how to go from here to there. And so if you've got deficiency in these molecules, then you've got problems with leukocyte trafficking. And leukocyte adhesion deficiency is one of those classic ones that are associated with integrin dysfunction, where you see neutrophilia, lack of pus, because it's not that the neutrophils are non-functional, they just don't know how to get to the site of where they need to go, the site of inflammation, to mediate an immune response. Let me just stop here for 1 second and say, Michelle, do we have another 5 to 7 minutes, or should I stop here?
Maybe like another 2 to 3 for kind of big points. Yeah.
Okay. Yeah. Okay. So I'll just go over the highlights. So when we think, so we've talked about the adaptive immune system, we've talked a little bit about the innate immune system with integrins and neutrophils, and then we think about complement. And there are, of course, certain conditions when we think about complement deficiency. And this is a slide that I created myself, but it's based on this paper that's actually, sorry, it should not be in press, it's published, and you can look that up. So I won't take time to go over it since we don't have time. But it's sort of a nice sort of overview about when to think about which complement pathway to look at when you suspect a complement deficiency. But from a laboratory perspective, when you send out for complement testing, there are a number of pre-analytical challenges that you have to keep in mind that can affect your interpretation of complement results. And for anybody who's interested, I'm happy to discuss this at another time. And I don't have time to belabor the point regarding NGS technology. Suffice to say that many of us are familiar with targeted gene panels, where we look at, anywhere from small panels to large panels of 500 genes. Then we've got exome and genome sequencing. Each of those has their advantages and disadvantages. And we've discussed them at the Quad AI a number of times, so I won't go too much into detail about that. So just to summarize, I think, as I mentioned when we started out, it's like trying to hold an ocean in a teacup, because we've got just so many permutations and combinations, and we've just dipped our toe into this pool today. But I hope you've got a sense that, this field is evolving both clinically and in the laboratory diagnostically, and we have a number of tools to interrogate and evaluate these patients, and exchanging dialogue, because we can help you select the right test. We can help you with interpretation of these tests when we have the clinical details. So interacting with the clinical laboratory where you send these tests are quite valuable, both in terms of genetics as well as immunology. And many of the time you'll get genetic reports with VUSs. I will be addressing this at the Quad AI next year in a talk called How to Read a Genetic Report. So if you're interested, and you can attend that sort of session. I think I'll stop there for the moment.